Today we'll talk with you about main clinical syndromes of liver diseases. And we'll stop on such syndromes as jaundice, portal hypertension, hepatic insufficiency, hepatorenal syndrome, and cholestasis. Let's start from jaundice. We are talking about jaundice when we'll see yellowish color of skin and mucus. It is true jaundice, which appears due to increased level bilirubin in blood. Clinically and laboratory, we distinguish three types of jaundice: hemolytic, parenchymatose or hepatocellular, and obstructive or mechanical jaundice. If you see on this patient, you can see yellowish color of skin and visible mucus eyeball. It indicates about true jaundice due to increased level bilirubin in blood. Let's remember mechanism formation of bilirubin, or other word, mechanism pigmentary metabolism. Primary unbound bilirubin is formed due to destruction erythrocytes in reticular endothelial system. Unbound bilirubin not water soluble. It cannot pass through the kidney and can be revealed only into the blood. Unbound bilirubin with transport protein go into the liver where, due to activity of hyaluronic acids, it's conjugated. And we are talking about formation bound bilirubin, which on contrary from unbound water soluble, it may be removed with urine, can pass through the kidney, and as any substances, it's absorbed into the blood. But normally, we can reveal into the blood both bound and unbound bilirubin, but 75% will be unbound and only 25% bound bilirubin, because metabolism bound bilirubin is different and it's usually go through the gastrointestinal tract. Normally, bound bilirubin, together with bile, enters into the duodenum where will be formed urobilinogen, and normally it's completely absorbed into the blood and come back into the liver along system of portal vein. And in normal pigmentary metabolism, urobilinogen cannot be revealed in any specimen. Its cycle closed, it enters into the duodenum and again come back into the liver, where again transform bound bilirubin and again with bile enters into the duodenum. Other parts bound bilirubin go downward and into the large intestine. First of all will be formed steatobilinogen, and then steatobilin, which gives specific brown color of feces and remove from our organism. But every substance is obligatory absorbed into the blood, and all fraction of bilirubin metabolism also absorbed into the blood, and as they are water soluble, they pass through the kidney and remove with urine. As urabilin or combined fraction of bound bilirubin may be named as urabilinoids, which give specific yellowish, straw yellow color of our urine. But its amount is such low that cannot be revealed with usual method. And normally, we know that level bilirubin into the blood from 8.5 to 20.5 micromole per liter, 75% from them unbound and only 25% bound bilirubin. Feces obligatory called stecobilin, urine free from any substances pigmentary metabolism. Hemolytic jaundice appears due to excessive destruction of erythrocytes, and it is characteristic for the patient with hemolytic anemia. It may be accompanied with B12 folic deficiency anemia because size of erythrocytes in this pathology not correlated with lumen of capillary network and provokes excessive destruction of erythrocytes. Malaria, infectious diseases, and protracted septic endocarditis are named more often pathology which accompanied with hemolytic jaundice due to intensive destruction of erythrocytes. Let's see how will be changed pigmentary metabolism in this situation. Due to intensive destruction erythrocytes, blood overfilled with unbound bilirubin, which enters into the liver and exceed usual activity of hepatocytes. As a result, blood overfilled with bilirubin, especially with its unbound form. But as into the liver enters a lot of unbound bilirubin, level of bound bilirubin into the liver also will be increased, and all this bilirubin enters into the duodenum where will be formed urabilin. But it cannot come back into the liver. We remember this closed cycle from first slide. Because liver overloaded with conjugation unbound bilirubin, and all urabilin absorbed into the blood and will remove through the kidney. As a result, color of urine becomes dark with slight green hue. Other part bound bilirubin go with usual way through the large intestine with formation stecobilinogen and stecobilin, which amount also increases, and feces of the patient also becomes dark brown color. Because primary level unbound bilirubin increased, as a result, amount conjugated bilirubin also will be increased, which will be seen on dark color of feces and dark color of urine. What problems will be of this patient? Patient complains on weakness, sometimes giddiness, decreased work capacity due to anemia, because we remember cause of hemolytic jaundice is destruction erythrocyte, hemolytic anemia other one. Patient feels discomfort or pain in left and then right hypochondrium, Because we remember left hypochondrium, which is spleen, which is depot of destroyed blood cells. It's enlarged due to increased activity. Right hypochondrium, it's liver. It's also slightly enlarged due to increased activity. And patient can see that color of urine and feces becomes dark. We remember all bound bilirubin will be removed through the urine and feces. What can you see? On inspection, skin of the patient has specific lemon yellow color. Yellow due to jaundice plus white due to anemia. As result will be light or lemon yellow skin. On percussion and palpation will reveal increased liver and spleen, hepato and splenomegaly. Parenchyma of jaundice appears due to true affection of the liver parenchyma, and first of all it is characteristic for hepatitis with different etiology, liver cirrhosis, and any toxic affection of the liver due to poisoning with mushroom, arsenic, some medicines, alcohol. Let's see how will be changed pigmentary metabolism in this case. Process destruction of erythrocytes normal. Unbound bilirubin enters into the liver where will be formed bound bilirubin. But we are talking about active pathological process into the liver, which is characterized with destruction of hepatocytes, cytolysis. And then more intensive cytolysis, then more contents of the cells will go out and process normal metabolism of bilirubin will be disturbed. Bound bilirubin intensively absorbed into the blood. Because if you remember, hepatocyte tightly connected with blood network. And if the process destruction of hepatocytes increases, activity of hepatocytes decreases, and unbound bilirubin also cannot be conjugated completely. What will you see? Into the blood both unbound and bound bilirubin increases. Sometimes bound bilirubin prevalented. If bound bilirubin absorbed into the blood, its amount which go through the gastrointestinal tract decreases and will be formed urobilin, but it also cannot come back because affection of hepatocyte is absorbed into the blood. Will be formed light amount of stecabilinogen and stecabilin, which also absorbed into the blood, and all fraction bound bilirubin from gastrointestinal tract plus bound bilirubin which absorbed into the blood into the liver will be removed through the kidney. What will be? Kidney becomes dark and foamy because it's overrich with bound bilirubin. Feces becomes light because level of stecabilin diminish. Let's see on clinical picture. Patient complains of any problems which tightly correlated with affection of liver. And when you will answer on this question on exam, you must remember our first lecture about liver examination and name all complaints which are characteristic for liver diseases. There are discomfort in right hypochondrium, problem with digestive system, jaundice, and any other problems. If patient attentive to yourself, he can see that his urine becomes dark and foamy, like beer, feces becomes pale. On inspection, will reveal yellow skin, and then more long this process, then more dark becomes skin, and it has light orange tint. Due to metabolism of bilirubin into the skin. On percussion and palpation will reveal hepatomegaly because process localizes into the liver. And last variant of jaundice, obstructive or mechanical jaundice, which is characteristic for the patient with cholelithiasis, period when the stone obstructs bile duct or gallbladder. And we remember about outside compression due to canceromatous process of the pancreas head. Let's see how will be changed pigmentary metabolism in this case. Process destruction of erythrocytes usual. And normal count unbound bilirubin enters into the liver. No problem with liver also. And level of bound bilirubin correlated with unbound. But it's hold into the liver because bile duct obstructed due to inside or outside compression. As a result, a process destruction erythrocytes continues. As a result, liver overfilled with bound bilirubin because bile cannot be evacuated. Its pressure increases and all bile element absorbed into the blood. Blood overfilled with bound bilirubin, which significantly prevalented over unbound. Bound bilirubin water soluble and it may be removed only one way through the kidney. As a result, urine of the patient becomes dark and foamy, a feces colorless. We are talking about echolalia. Because if bile doesn't go through the gastrointestinal tract, stecabilin cannot be formed. Feces colorless, echolic feces. It also helps you in differential diagnosis because in parenchymatous jaundice, feces pale, urine dark. In obstructive, urine dark, feces completely colorless. Let's see clinical characteristic of this jaundice. It depends from primary pathology. If the cause of obstructive jaundice is cholelithiasis, patient enters in hospital with attacks of biliary colic. He complains of severe spastic pain in right hypochondrium. If the cause of obstruction outside compression due to growth of pancreas tumor, patient complains of dull pain or discomfort. We remember that feces of the patient colorless, echolic, grayish or gray-white color, urine dark brown and foamy, beer-like. On inspection, we can see yellowish color of skin, and sometimes it has specific green or dark olive color, especially for the patient with canceromatous process into the pancreas, because gradual obstruction and long-standing process. On percussion and palpation, we can reveal pathological symptoms from gallbladder or pancreas, especially positive viscerocutaneous reflexes. For gallbladder will be positive tapping and pressing symptoms. Now let's formulate finally opinion about differential diagnosis any type of jaundice. First of all, we'll pay attention on correlation between blood-bound and unbound bilirubin. We'll check urobilin and in urine and feces steatobilin. If our patient with hemolytic jaundice in blood prevalent unbound bilirubin, urine is rich with urobilin and feces rich with steatobilin. No bilirubin in urine, as a result urine will be dark color but not foamy, because foaming is predilection of bound bilirubin. Parenchymatous jaundice. Unbound and bound bilirubin approximately same. Urine is rich with both urobilin and bilirubin. Feces light due to diminished level steatobilin. Obstructive jaundice. Bound bilirubin prevalent into the blood. Urine is rich with bilirubin, but no steatobilin and urobilin in urine. Next syndrome on which we'll stop, it is cholestasis syndrome. And I'll pay your attention. Cholestasis is disturbance of the synthesis, secretion, and outflow of bile. All process of the bile synthesis and evacuation will be disturbed. We are talking about cholestasis, and it can have extrahepatic and intrahepatic origin. Extrahepatic origin, it is cholelithasis or canceromatous process into the pancreas. Other word, it is obstruction bile duct, common bile duct, or gallbladder bile duct. Intrahepatic cholestasis appears due to restriction of the blood flow into the liver. Usually it is characteristic for the patient with liver cirrhosis and maybe characteristic of the patient with toxic hepatitis. When the cytolysis active and bile stagnated into the liver and absorbed into the blood. Extra and intrahepatic origin of cholestasis. Patient complains, first of all, on pronounced skin itching due to increased level of bile acid into the blood, which intensifies by night due to irritation vagus nerve. From physiology, you know, during night period, parasympathetic nervous system prevalent, it is activity of vagus nerve. Patient can complain of jaundice. It may be more or moderately intensive depending on origin. And he can pay attention that urine will be dark, feces pale, and due to complete obstruction of bile duct, completely alcoholic, colorless. On inspection, we can see jaundice. We can see scratches on the skin due to skin itching, and we can see result disordered fat metabolism because it is some part of the cholestasis syndrome. As a result, we can see formation specific yellowish plaques on the eyelids, xanthelasma, and elbow xanthoma. For diagnosis, we'll use blood analysis, and first of all, we'll pay attention on alkaline phosphatase, which is main index of cholestasis. We can reveal jaundice due to increased bound conjugated bilirubin and increased level cholesterol. We'll obligatory send our patient on ultrasound, sometimes needed computer tomography, and sometimes patient needed liver biopsy to clear cause of cholestasis. You see patient with severe skin itching and formation of scratches. If the cholestasis prolonged and process formation synthesis of the bile significantly disturbed, especially it is characteristic for the patient with liver cirrhosis, biliary liver cirrhosis, maybe primary or secondary biliary liver cirrhosis, we can reveal problems with common metabolism because all metabolic processes in our organism tightly connected. Deficiency of the bile impaired excretion of bile acids which hold into the blood, provokes violation of digestion and dietary fat absorption, because we know that normal fat metabolism started from normal digestion of fat into the duodenum. It's tightly correlated with properties and evacuation of bile. As a result, fat incompletely or completely undigested removed with feces, and we see steatorrhea, fatty feces. Usually it's accompanied with diarrhea. As a result, patient loses fluid. Together with fluid, he loses electrolytes, which diluted into the fluid. Deficiency of lipids, accompanied with deficiency of liposoluble vitamins A, D, E, K, which manifested with specific clinical signs. Patient complains of night bleediness, loss vision during night period due to deficiency vitamin A, osteomalacia due to deficiency vitamin D, predilection to bleeding due to deficiency vitamin K, and later it's accompanied with malabsorption and progressive weight loss. but it is not often process. I pay you attention. It is characteristic only for long-standing cholestasis, usually for the patient with biliary liver cirrhosis. Next syndrome on which we stop, portal hypertension. Increased pressure in the system of portal vein due to intrahepatic block, which is characteristic for patients with liver cirrhosis because it is characterized with abnormal growth of connective tissue in the intralobular space and as a result restriction blood flow. Rare case, portal hypertension appears due to subhepatic block, thrombosis of the portal vein or its branches, due to growth of tumor or enlarged lymph nodes into the abdomen, or formation of cancer metastasis. And suprahepatic block due to occlusion of hepatic veins as manifestation of specific Bardet-Chiari syndrome. But more often, we'll meet patients with portal hypertension as complication of liver cirrhosis. But we must remember about other origin of this problem. What is characteristic of portal hypertension? If you remember its principles, you can easily explain clinical symptoms. Due to restriction blood flow through the system of portal vein will be formed porta-caval anastomosis. Due to increased pressure into the portal vein, some blood absorbed into the abdominal cavity will be formed ascites. Due to progressive problems with liver, in pathological process will be involved spleen. And if we are talking about liver cirrhosis, will be specific correlation. Size of the liver progressively diminish, size of the spleen progressively increases. If we are talking about portal-caval anastomosis, because blood go bypass of portal vein, we are talking about formation pathological plexus, and first of all, low porta-caval anastomosis with formation hemorrhoidal venous plexus, upper porta-caval anastomosis with formation esophagogastric plexus, and cava-caval anastomosis with dilation paraumbilical vein system and formation specific visible symptoms caput medusa. You must remember, three pathological processes are characteristic for portal hypertension: formation porta-caval anastomosis, ascites, and splenomegaly. You see that system of portal vein is needed to pass blood from gastrointestinal tract, which must obligatory pass through the liver with purpose of detoxification, because this process holds our organism from itself intoxication. We see mechanism formation of upper porta-caval anastomosis, esophagogastric. You see formation of caput medusa, cava-caval anastomosis on abdominal wall, and lower porta-caval anastomosis with formation of hemorrhoidal plexus. It's not usual disease hemorrhoids because it has other origin. You see patient with dilated hemorrhoidal veins. Complaints of the patient. Patient can enter in hospital with acute situation, bleeding from ruptured esophageal vein or hemorrhoidal veins. Patient feels discomfort and or pain in the left hypochondrium due to splenomegaly. Patient can complain on enlarged abdomen and heaviness due to ascites. On inspection, we can see enlarged abdomen due to ascites. We can see caput medusa due to cava-caval anastomosis and will obligatory examine spleen to reveal splenomegaly and palpate and piquage abdomen to clear ascites, on which we'll stop additionally later. And for clearing of disease, we'll use ultrasonography, which help assess size of the liver and spleen, and especially diameter of the portal and splenic veins, which is our main indexes of portal hypertension. We'll send our patient on esophagofibragastroscopy to reveal dilated esophageal vein and proctosigmoidoscopy to reveal hemorrhoidal vein. And on this slide, you see patient with esophageal bleeding due to rupture of dilated esophageal vein. Which may be stopped only with special surgical method when we'll introduce specific Blackmore balloon, which press on the esophageal vein and stop bleeding. Patient can enter bleeding from the hemorrhoidal vein, or he can see blood during defecation. We'll examine spleen to reveal splenomegaly. I said you opposite correlation with size of liver. Liver diminished, spleen enlarged. We can see enlarged abdomen due to ascites and visible dilated vein on anterior abdominal wall, caput medusa. Esophagofibragastroscopy revealed dilated esophageal vein. Proctosigmoidoscopy revealed dilated hemorrhoidal vein. Ultrasonography revealed enlarged spleen and diminished liver. You see size of spleen and liver approximately same, because we remember about opposite correlation, diminished liver, enlarged spleen. I said you about diameter of the portal and splenic veins, because there are main index of portal hypertension, and we can see level of liquid in abdominal cavity, ascites. Computed tomography reveals same problems, splenomegaly and liquid into the abdominal cavity. I won't stop on the principal diagnostic of the ascites, because this question will be given separately on exam. And as any syndrome, it must be explained with full characteristic. Now we remember complaints of the patient on enlarged abdomen and some discomfort, heaviness. On inspection, doctor will see enlarged abdomen with protruded navel and dilated vein, caput medusa, if the ascites is caused by portal hypertension. You see protruded navel, which help differentiate ascites from obesity. On percussion will reveal dull sound over the liquid and will obligatory do percussion in two position of the patient. First of all, vertical position will percuss along linea alba from xiphoid process downward before dull sound and put mark on the level of liquid. Then horizontal position will percuss from the navel to the side and again put mark on the level of liquid. Then we'll turn our patient any side and level of liquid will be increased on the side on which patient in line position, because liquid from opposite side go downward due to physical law. It helps you differentiate true liquid from dull sound because filling intestine with feces. Obligatory vertically and horizontally. First of all, when the patient lies at back, and then on side. On palpation will determine fluctuation syndrome, but when you demonstrate this methodic onyx, then remember please that you will need it in assistant, which put hand along linea alba to prevent vibration of peritoneum. Because when we'll tap one side of abdomen, other side we must feel only vibration of liquid. Your assistant prevent vibration of peritoneum and exclude false conclusion. Ultrasonography helps reveal level of liquid into the abdominal cavity, same as the CT scan, which also show level of liquid into the abdominal. Principles of the treatment. First of all, we'll prescribe diuretic medicine because there are main principles for resolution of edema. But if this method not effective, we'll use laparocentesis, puncture of abdominal cavity, and will actively remove liquid. It is small surgical manipulation, invasive method which has some complication because if we remove large amount of liquid, maybe hypohydration. Together with acidic liquid will remove protein, can provoke hypoproteinemia and any other complication. You must remember whenever we'll start from invasive method. First of all, we'll use non-invasive. If they're not enough or not effective, we'll use more and more heavy therapy. Hepatorenal syndrome. No, its name show you. We are talking about hepatorenal syndrome when simultaneously will be revealed spleno and hepatomegaly. Both organs enlarge. On exam, when you reveal this syndrome, you percuss or palpate liver and spleen, obligatory both organs. And only when both organs enlarge, we can say about hepatorenal syndrome. It is characteristic for some liver diseases, initial stage of liver cirrhosis, hepatitis, especially acute hepatitis, toxic hepatitis, canceromatous process, We must remember about blood diseases. Some minutes ago we said about hemolytic and B12 deficiency anemia when both spleen and liver involved in pathological process. But first of all, we remember about leukemia. We must remember about some infectious diseases. And first of all, there are malaria, typhoid fever, poisoning, toxic hepatitis, poisoning with alcohol, with some medicines, with some food. Thrombosis of the hepatic veins due to disordered blood flow provokes splenomegaly. And some spleen diseases. No, it's more rare problems. I put pathology depending the activity. And first of all, hepatorenal syndrome is characteristic for liver, blood, and infectious diseases. Let's stop on clinical manifestation. Patient complains of pain, both left and right hypochondrium. It depends from primary diagnosis. Patient with liver diseases, first of all, hepatomegaly, then splenomegaly. If blood diseases, first of all, spleno, then hepatomegaly. In infectious diseases, may be simultaneous enlargement of spleen and liver. And you understand that complaints will be, first of all, connected with main diseases. If liver diseases, we'll remember liver problems. If blood diseases, you will name pathological signs of blood disease, and first of all, hemolytic anemia and leukemia, about which we'll talk next lectures. On inspection, we can see asymmetric protrusion of abdomen, right and left hypochondria, but we must remember it depends from attention of the doctor and constitution of weight and weight of patient. It's more easy seen patient with athenic constitution and decreased weight. And you understand the difficulty revealed of the patient with obesity and hypertonic constitution. But we have clear pathology with percussion and palpation, which helps reveal size of the spleen and liver and reveal hepato and splenomegaly. To clear our primary opinion, we'll obligatory send our patient on additional, first of all, instrumental examination. Ultrasonography or computer tomography will be dependent from primary diagnosis. Patient with leukemia, more optimal computer tomography because we want examine lymph nodes into the abdominal cavity and it gives more full characteristic. If a patient with liver disease, sometimes ultrasonography may be enough. Hypersplenism. We'll ask you about hypersplenism during interpretation of blood analysis. And we'll obligatory ask you, what is it? And oftenly you answer, it is enlargement of the spleen. But 1 minute ago we said enlargement of the spleen is splenomegaly. Hypersplenism, it is increased function of the spleen. Our main function of the spleen is control of the blood cells and their destruction. As a result, into the blood will be revealed decreased level of red blood cells, anemia, white blood cells, leukocytopenia, platelets, thrombocytopenia. Other word, blood becomes poor with blood elements because they intensive destruction into the spleen. In blood analysis will be revealed pancytopenia due to increased activity of the spleen. I want that you differentiate pancytopenia due to depression of bone marrow or due to increased activity of the spleen. For this purpose, will obligatory oriented on blood analysis and puncture of bone marrow. And if pancytopenia in blood accompanied with increased number of blood cells in bone marrow as protective response on pancytopenia and will reveal splenomegaly, we are talking about hypersplenism, sometimes needed surgical correction, splenectomy. But if pancytopenia accompanied with decreased numbers of the cells in bone marrow also, which indicates about primary problem with bone marrow due to its depression, aplasia. And I'll again pay your attention. We are talking about hypersplenism due to increased functional activity of the spleen, which manifested with splenomegaly and pancytopenia in blood analysis. And last syndrome on which we'll stop today is hepatic insufficiency, which may be both acute or chronic, which is revealed from anamnesis. Anamnesis morbid, first of all, will obligatory ask the patient how long he sick. Acute hepatic insufficiency appears in any severe acute situation with active destruction of hepatocytes, cytolysis, and first of all, it may be grave complication of acute virus hepatitis. We must remember about poisoning with hepatotropic substances. And first of all, there are phosphorus compounds, arsenic, large dosage of alcohol, or fungus, which also provoke active cytolysis, which not correlated with regenerative ability of the liver. You understand that any acute process is developed faster and often finish with death of patient. Chronic hepatic insufficiency is complication of any chronic liver diseases, hepatitis, cirrhosis, hepatocarcinoma, when the hepatocytes slowly but progressively destroyed and change their activity. Clinical signs of hepatic insufficiency, not tightly correlated with liver function, because we say about insufficiency due to dysfunction of liver. And first of all, there are progressive decreased detoxificated function of liver. We are talking about liver as vital organs, because without liver will die from itself intoxication, from disordered metabolism. Liver encephalopathy may be revealed during talking with patient when we'll see some non-adequate behavior. Early encephalopathy, which are invisible, may be revealed with specific writing tests. You see, patient cannot interconnect some figures. His writing also will be disturbed. Later will be visible signs of liver encephalopathy as tremor of extremities and progressive non-adequate behavior with next disordered consciousness. Other signs of liver insufficiency is progressive edema ascitic syndrome, because we remember liver takes active part in protein metabolism, and first of all due to synthesis of albumin, which is needed for control of oncotic pressure. If the synthesis albumin decreases, we are talking about hypoalbuminemia, blood cannot be held into the vessels. It's absorbed outside. As a result, will be hold liquid in subcutaneous fat tissue, edema, and into the inner cavities. First of all, into the abdomen, ascites. Then it may be held in pleural and pericardial cavity. And this edema cannot respond on activity of diuretic medicine because it's hypoproteinemic edema. And to remove liquid from the body, first of all, we must come back oncotic pressure, come back level of albumin. Next problem, hemorrhagic syndrome, because liver control coagulative blood properties due to synthesis of prothrombin and other coagulative indices. It takes part in vitamin and microelements metabolism. In liver insufficiency due to deficiency vitamin C, K, will be disturbed coagulative blood properties and permeability of vessels. Patient predilected to bleeding. And progressive jaundice due to disordered pigmentary metabolism. There are many signs of the hepatic insufficiency, but I'll pay your attention on the liver encephalopathy, because jaundice may be primary signs of liver pathology in any exacerbation of chronic hepatitis. Ascites may be signs of portal hypertension, and only when ascites doesn't respond on diuretic medicine, patient predilected to bleeding and progressively depress his psychic activity and consciousness, we are talking about liver insufficiency. When we are talking about chronic liver insufficiency, we know that it develops gradually and we can distinguish some stages. We remember principles of classification on stages. Early compensated stage, invisible, may be revealed only with special tests. We see that level albumin progressively decreases. We see that bilirubin level doesn't respond on our therapy. We see primary signs of liver insufficiency. Then visible subcompensated and pronounced decompensated stages. when the all symptoms liver dysfunction is seen. And last, terminal dystrophic stage, when the amount of active hepatocytes significantly diminish, and we see patient with unconscious condition, hepatic coma, because first of all, brain go out as response on progressive intoxication and disordered metabolism. And usually, high percentage of patients with hepatic coma will be lost because liver used all its compensatory response. And we can send our patient on liver transplantation in period of pronounced decompensation, because terminal period we cannot use this method because condition of patient contraindicated to any surgical manipulation. Let's give clinical characteristic of liver insufficiency. All stage, I said you, clinical symptoms absent, no visible signs, patient unknown, doctor cannot see. No, sometimes patient can say that more severe weakness. Doctor, if very attentive, can find some signs of non-adequate behavior. And I said you about specific test for early encephalopathy. But we'll send our patient on some laboratory test. I said you it slightly deviates or lower level of norm. Second, visible stage. We can see clinical signs of liver dysfunction. And first of all, profound neuropsychic disorders. I said you about finger flapping tremor. Patient complains of progressive weakness, his walking activity progressively decreases. I said you about progressive jaundice which not responds on usual therapy. Pronounced ascites which also doesn't respond to usual diuretic medicine. Will be progressive dyspeptic disorders, and you'll understand if the vital activity decreases, patient progressively loses appetite, because appetite tightly correlated with our vital activity. Third, final stage characterizes with deep metabolic disorders. Will reveal problem with all metabolic process, and as a result will be profound clinical manifestation. No, first of all, patient progressively loses weight. You see no subcutaneous fat tissue, thin extremities, visible ribs, and only enlarged abdomen due to progressive ascites and edematous syndrome. Will be decreased vital activity because no energy due to disordered carbohydrate metabolism. Disordered protein metabolism, all metabolic process becomes slow and not effective because protein is main element of any enzymes, plus deficiency of coenzymes, vitamin and micro elements. And due to progressive intoxication from primary irritative disorder, patient progressively loses consciousness. First of all, stupor, patient slightly delayed, then SOPE, more intensively delayed, and may come back only after intensive stimulation, and final stage, hepatic coma. Precomatose period, characterized with pronouncing of all named symptoms and progressive depression consciousness. And when the patient completely loses consciousness, we are talking about final terminal stage. I said you, during precomatose period, we can reveal all stages of disordered consciousness, from irritative disorders, period of depression with hallucination, irritative period, then more deep inhibition, stupor, SOPE, then we can see formation of pathological reflexes. Dysarthria, patient cannot take and hold any subject, but we see progression of sucking and grasping reflexes. If our patient with liver cirrhosis, we see progressive decreased size of liver, and very bad when this period very fast. For example, you reveal liver below rib arch, after 2-3 days it's nearest rib arch, and then it's completely impalpable. Very fast diminished size of liver, progressive growth of connective tissue. We see progressive jaundice due to cholestasis, especially patient with liver cirrhosis, patient with growth of tumor outside obstruction, and due to cytosis, active destruction of hepatocyte and all its contents hold into the liver, because abnormal correlation between bile ducts. During this period, we can reveal increased body temperature. If you remember all other lectures I said you, for usual chronic developments of gastroenterological diseases, fever not characteristic. Rare case, it only indicates about specific purulent process, for example, acute cholecystitis, or a toxic process, if we are talking about liver, impaired detoxificated function of the liver, and some pathological substances which hold inside the body and becomes pyrogen agent for our organism. Due to decreased protein metabolism, will be decreased immune response, because protein is needed for normal synthesis of immunoglobulin. Plus, we said about disordered fat and electrolyte metabolism, which is normal structure of membrane and inner organ. And due to decreased immune response and due to increased permeability of intestinal wall, primary aseptic peritoneal liquid becomes bacterial. And we are talking about spontaneous bacterial peritonitis. You see two mechanisms of the fever. First of all, due to primary decreased detoxificated function of liver. Secondary, due to decreased immune response, due to disordered protein and fat and electrolyte metabolism. We said about pronounced edema and ascites, which short time may be decreased only with puncture of the abdominal cavity, which is caused by hypoalbuminemia, no oncotic pressure, and blood hemodynamic disturbances, because final stage of any insufficiency is characterized with involvement other organs in pathological process. And patient with progressive liver insufficiency, final stage cardiovascular system obligatory involved in pathological process. Progressive hemorrhagic syndrome. First of all, patient can complain of predilection to gums and nose bleeding, and then we can see skin manifestation. We can see petechiae on the skin due to hypofibrinogen and prothrombinemia, problem with permeability of vessels due to deficiency vitamin C and PP, and blood hypersplenism. We remember about tight correlation of liver and spleen. Hypersplenism, which is active destruction of all blood cells, and first of all, thrombocytopenia, all mechanisms which control coagulative blood properties disturbed, progressive hemorrhagic syndrome, and patient can die from profuse hemorrhage. We see progressive loss of weight, first of all due to disordered fat metabolism and hypolipidemia, are later due to progressive dyspepsia. I said you, if vital activity decreased, patient loses appetite. Taking food cannot be adequately digested because synthesis of bile disturbed in liver insufficiency, and all mechanism of digestive process will be progressively disturbed. And as a result, patient go in comatose stage, and from hepatic coma, 80% patient died, because if the patient revealed in the stage of hepatic coma, it shows that all protective response of the liver was completely used, and we lost time for liver transplantation. Pathogenic mechanism of hepatic coma. Now, first of all, it's self-poisoning of the body due to halt of non-detoxicated final products of ammonia and phenols metabolism. And first of all, it is result of toxic protein metabolism. You know that protein which taken with food is very toxic for our organism. And first of all, period of liver insufficiency will restrict protein from food, and first of all animal protein, and will introduce protein substances only as a transfusion, parenteral nutrition. Electrolyte metabolism becomes absent, and first of all we'll check level of main microelements, sodium, potassium, calcium, chloride. Will reveal progressive hypokalemia and alkalosis. Usually, you know, pH of our organism is light alkaline or light acid. And acidosis, easy release, on contrary from alkalosis. It's more heavy for our organism. Provoke factors of coma. It may be provoke of patient which not go to doctor's recommendation, or sometimes it may be result incorrect treatment or some doctor's manipulation. Now, first of all, in any liver diseases, alcohol must be obligatory exclude because it first provoke factors of progressive liver pathology. Then we must carefully prescribe barbiturates and some analgesic medicines. You remember? First, signs of encephalopathy manifested with deranged sleep, with predilection to some irritative disorders, and doctor can prescribe barbiturates to help the patient very carefully and with reduced dosage. Same order for analgesic medicine because there are more toxic substances for liver. We must remember about diuretic medicine. You see, progressive ascites will increase dosage of diuretics. We combine different groups of diuretic. Forgot about protein origin of ascites and edema. And in this case, diuretic not effective. We must stop increased dosage of diuretic and exclude this medicine from the treatment before comeback level of albumin in blood. And in this case, we'll prescribe transfusion of albumin and control protein and albumin. When level of albumin come back to normal, we can again prescribe diuretic medicine. I said you about dietary recommendation, about restriction of protein. If the patient forgot about it and take protein-rich diet and blood alcohol, we can see him only with hepatic coma. We must remember about provoke factors of hemorrhage and sometimes profuse hemorrhage, especially from esophageal vein, sometimes rectal vein, maybe provoke factors of hepatic coma and death of patient. We must remember about paracentesis. And if we remove ascites only with surgical manipulation, we must remove it with gradually. Not all ascitic fluid simultaneously. Sometimes it may be 15, 20 liters. I said you. It provoke hypovolemia, hypoproteinemia, and hypovolemic shock. We must remember about provoke factors of diarrhea because patient loses water, electrolyte, and provoke electrolyte disorders. And we must hold our patient from infectious disease because we remember about decreased immune response. And we remember about spontaneous peritonitis. Comatose period. No, first of all, patient doesn't respond on our stimulated agent. We can see motor anxiety with pathological reflexes, sucking, grasping. If you put some spoon to the lips, we can see sucking. If we put some subject to the palm, grasping reflexes. But patient unconscious. We can see convulsion due to disordered electrolyte metabolism and first of all due to hypokalemia. Patient doesn't control physiological process. We see incontinence, defecation and urination, or maybe opposite. Urine and feces cannot be independently evacuated. Patient needed catheterization of urinary bladder and siphon enema to cleansing of intestine. Breathing of patient becomes deep and loud, slow, deep, loud. We are talking about Kussmaul respiration. Patient breath has specific smell. We are talking about sweety hepatic or rotten apple. sweat from the patient's skin and mouth because some toxic substances will be removed through the respiratory tract and skin, which indicates about liberation of methyl mercaptan, which is formed in deranged methionine metabolism. And to prevent this process, will prescribe specific detoxificated treatment. Diagnostic process of liver insufficiency. No, first of all, will assess psychic behavior of the patient to reveal signs of encephalopathy due to decreased detoxificated function of liver. Will pay attention on ascites, laboratory tests, obligatory specific changes in blood analysis, anemia, leukocytosis, increased ESR is secondary bacterial infection and result of hypersplenism. Level of bilirubin increases. We reveal decreased protein metabolism, hypoalbuminemia, low counts of platelets and fibrinogen, disordered coagulogram of the patient, and first of all, we'll pay attention on prothrombin index. We can reveal other electrolyte disorders, hyponatremia, hypokalemia, metabolic acidosis or alkalosis, contents of urea in the blood, serum increases due to formation hepatorenal syndrome. You know, we have two organs which control our organism from himself intoxication, is our liver and spleen. And if the activity of liver decreases, activated kidney activity, and opposite, depression of kidney, involvement of liver in pathological process. And we can, to reveal early liver insufficiency, we can send our patient on respiratory test, 13-metacytine test, to reveal early signs of liver dysfunction. And I'll again pay your attention. Main indices for diagnosis of liver insufficiency: psychic behavior, encephalopathy, ascites, level of bilirubin, albumin, and prothrombin index and prothrombin time. And depending on activity of these indices, we have special Child-Pugh scale, because every index correlated with bulk, and depending the counting, we can clear 3 stages of liver insufficiency: A, B, and C. And depending result will oriented about time when may be recommended liver transplantation. And last question on which I want to stop today, there are hepatorenal syndrome, involvement kidney in pathological process. It is characterized with violation of glomerular filtration due to function genesis on the base of liver disease. And if you know that patient with primary progressive liver pathology, and after sometimes we reveal problem with kidney activity, decreased glomerular filtration rate, its main index of renal insufficiency. Patient not needed specific renal therapy. All attention on liver, and when will come back or correlate correct liver activity, renal insufficiency disappears independently. More often, signs which provoke formation hepatorenal syndrome, which is progressive liver insufficiency, which is portal hypertension with progressive ascites, because it provokes factors disordered electrolyte metabolism, and progressive arterial hypertension, because we know filtration of urine tightly correlated with blood pressure. No blood pressure, no adequate filtration of urine, progressive decreased glomerular filtration rate. Clinically, it's manifested with decreased diuresis to oliguria. We remember oliguria, its level of urine less than 500 milliliters per day. Decreased glomerular filtration rate and will be changing indices of blood. As a result, delayed nitrogenous will be increased urea and creatinine in blood analysis. We can reveal disordered electrolyte metabolism, hyperkalemia, hypochloremia, alkalosis or acidosis depending on stage of liver insufficiency. That's all information. It is last lecture of this module. With your division, we'll meet next module. Goodbye, be healthy, and pay attention on all information which given you during lectures and practical classes. Thank you for your attention.